Right. To unmute themselves. And the four of us want to welcome you to our session this afternoon entitled Why Diversity, Equity, and Inclusion in the Health Professions Are Important for Everyone's Health. I am Dr. Julia Chevan. I am a professor of physical therapy and chair of the Department of Physical Therapy. And at this moment, I'm also a pretty proud faculty member because I've been working this semester with 3 students who took on the task of creating this presentation, doing a lot of learning, and figuring out how to distill what they learned into, I think, what's going to be a pretty amazing afternoon. They have been phenomenal. It's really mostly their presentation. I'm going to give some background, and then I'm going to leave it to them and to some of the guests that they've invited in to talk as well. This was these are actually what we're hoping you're going to come out of today with, that you're going to walk away today prepared to learn about, to think about, and to consider what we and our guests, we've invited a number of guests to join us, what we talk about in relation to the demographic makeup of the health professions, how professions that are demographically homogeneous serve populations that are diverse. How can we target the factors that lead to poor health outcomes? And how do we improve health equity and healthcare access? And after you've done your learning and thinking and considering at the end of today, what we're going to talk about is how do you act in the name of change? So our first, the majority of this will be hopefully some learning and considering and thinking, and then we're going to talk a lot about action. So I'm going to let my 3 co-presenters introduce themselves. I think you're first, Xavier.
Perfect. Yep, so I'm Xavier. I'm a 4th year here at Springfield, and I am a first year grad student in the PT program. So why this is important to me, kind of why I started this whole process. So it definitely started with self growth. So I had gone back from Spain in the spring and saw firsthand the differences in culture. I learned a lot. Felt as though that I grew a lot as a person as well. And then with everything going on this summer, it seemed impossible to avoid reflection. So I had to reflect on, the current social environment, my community, the nation, the world, and myself. I asked myself, what am I doing to make a difference? How am I being better in this process? What I realized is that I had to do better. Being a student of the health professions, we're here to learn, serve, help, and advocate for the public. I owe it to my parents, my siblings, my grandparents, my community to be a part of the change, to not only identify health disparities, but also come up with solutions. We become so focused, as students on our next exam or our next paper, our next assignment, and we kind of lose sight of the end goal. We chose a profession to help, to advocate, to treat those who need it, the most, and that's what it's all about. If there is a certain subgroup of people who are struggling, you can't ignore that, but better yet, why not be a part of the movement to correct it? As a Black and Hispanic healthcare student, I felt a level of responsibility to do my part and educate and bring awareness to those who the healthcare system isn't made or designed to benefit. So that's my long reason.
All right, so I'm Katie Skowronek. I'm also a first year DPT student. And I got involved because as a future physical therapist, I have a job to help students get back, or patients to get back to their optimal functional status and help improve their quality of life. But more importantly, I have a voice to advocate for my future patients. We live in a world that's like blinded by bias, inequity, injustice. And with the health of others in my hands, I have a job to educate myself about disparities in health and the factors that contribute to this, to understand each and every single patient that I come into contact with. In the past, I kind of held my beliefs silently, but have come to realize that even though these topics can be uncomfortable to some, they need to be talked about and they need to be normalized. The healthcare field needs to do better, and that's kind of why I got involved.
Hi, my name's Katie Everton, the other Katie. I got involved in this project a little bit later on. Xavier had already had the idea and I was just like, can I please be a part of this? I had taken a class called Sociology of Health and Healthcare with Dr. Susan Joel. big plug, take that course, one of the best undergraduate courses I've ever taken. And it really awakened this need to advocate for others in me, because you learn so much about the disparities that go on in the world. And then this summer, we started our graduate program. And with George Floyd and the protests going on, it just seemed like, how can I do more? How can I do more in this profession that I love so dearly? So this is it. This is how we do more. We learn, we educate, and then we share what we learn with others. And then we act. So that's why I got involved.
So when these three came together and decided to do this project with me, I gave them this statement, and they used this as the starting point for their investigation of the issues. So this was what I wrote, and they agreed to work on this. BIPOC folks, queer folks, and members of nearly any marginalized group or the intersection of these groups in the United States face numerous barriers to healthcare access. These barriers produce health-related outcomes that should shame health providers and health insurers, including the federal government, in this resource-rich and privileged nation. The outcomes are compounded by the fact that these folks are underrepresented in medical school and health professional education from roles as students, faculty, and researchers. Students' experiences in programs are often fraught with biases. The experiences are more likely to perpetuate stereotypes and structural inequities than fix them. And so they're joining me to try to present to you our approach to what we learned and our answer to some of the fixes. So my role now is to give you a little background before they really dig into the content. And a lot of this background is just to throw some words out at you that you're going to hear over and over again from the students and their guests. I'm as a physical therapist, my background actually is also in public health, and a lot of my research revolves around public health. And I'm certainly interested in all of the factors that come together to create health outcomes. And, you know, in public health, we talk about two major outcomes. One of them is mortality or in life, length of life, and then the other one is quality of life as a health outcome. These are not the be-all and end-all of outcomes, but they're the way that we often think about outcomes in healthcare. And this is a model that I've actually used with students before and in some of my work. And what I really like about this model is that we're going to talk today about health providers, and I just want to draw your attention to how small a role health providers might be playing if you use this model. Only 20% of health outcomes is actually dependent on health providers, because we're not providing health, we're providing health care. And really, health has so many other factors that relate to it. So the students spent some time this semester looking at the social determinants of health, and they'll talk about that. This is one model of the social determinants of health that shows you that health is actually determined by a number of factors, including economics, physical environment, education, food, community, social context, and then toward the end, again, the healthcare system. So it's not just the healthcare system that we're going to be talking about today when we talk about health and healthcare providers, who health providers ought to be, and what they ought to be doing. The other term that you'll hear the students and their guests talk about is health equity, and they'll be differentiating between equity and equality. Because in equity, we remove differences that are remediable among groups. And they'll talk a little bit more about what equality is about. But equity means that there is a fair and opportunity for everyone to have access to health. My starting point in talking to the students, I have to admit, was some statistics. And everything that I'm showing you here, they read. So almost every week there was an email from me, these are resources that I want you to read, and they read it. And this document was a report by something called the Sullivan Commission. Sullivan was the Secretary of Health and Human Services of the United States. And for me, I think they named this report so aptly. It's called Missing Persons: Minorities in the Health Professions. And this report, published in 2003, came up with 3 things that we needed to do in the health professions. We need to increase diversity. We need to improve the culture of health professions schools. We need to create new and non-traditional paths to the health professions. And we need to put these commitments to the highest levels. So that's a great report from 2003. And I reread it as part of our project. And as soon as I was done reading it, I thought, oh wait, was this written last night? because really nothing's changed since 2003. So the report is still relevant and still worth a read, and I know that these 3 students read it, and you'll hear some of their reflections on it. The other thing I passed on to them, because I admit that I'm a little bit of a data head, was some data. This data comes from the American Community Survey, which is from the Department of Health and Human Services. And the ACS, the American Community Survey, is data that's done collected ongoing and is always available. And they came out with a healthcare workforce analysis looking at sex, race, and diversity. It turns out that in these occupations we're talking about, so this doesn't include medicine. These are the professions that are mostly at Springfield College and some that are not. Female workers represent the majority. There is some diversity in racial and ethnic makeup of the occupations, but actually that diversity falls mostly in the occupations that earn the least, like personal care attendants and nursing assistants. All minority groups are underrepresented in that group of professions called the health diagnosis and treating occupations. And at Springfield College, that would be PT, OT, PA, and speech and language pathology. And the data included counselors and social workers. They have some specific underrepresentation, but the most diverse group in healthcare are personal care and service occupations, which, let me remind you again, are the lowest paid group in healthcare. So this is what it looks like for the professions that we know of at Springfield College. I'm just going to have you focus on the orange color there, because the orange color doesn't change from slide to slide. Again, the data comes from the ACS. It's a little more recent than that report because I ran the analysis myself quickly to get this, but physical therapy, 78% white. Physician assistant, 73% white. Occupational therapy, 84% white. Speech and language pathology, 86% white. And I didn't put up here the demographic makeup of the United States, but you know, I'm assuming that you're in this room, you probably know that that's substantially different from what these slides show you. Some of you I thought might be curious about medicine, and so I include some data from the AAMC, which is the American Academic Medical Schools organization. Medicine has done a lot of work, could do more, but it's done a lot of work on improving its diversity. In medicine, what's changed is some of the makeup, but still 56% white in medicine. And what medicine's really had to work on, and I didn't pull this data for the other professions, is actually its gender mix. Because medicine is truly a traditionally male-dominated profession, and in fact, across all of the different categories, for the most part, it remains male-dominated. So, as you've gathered, the students did a lot of reading, and then after they did the reading, I asked them how they wanted to present this, and their idea was to actually go out and collect interviews and to be able to use these interviews to contrast the way people talk about this. So I went and connected them with 3 academic faculty who are noted for their work on diversity, equity, and inclusion in physician assistant studies, in physical therapy, and in occupational therapy. And in fact, these 3 faculty at their home institutions within their departments hold the role of vice chair or chair of diversity, equity, inclusion within the department. So there's a department level role specific to diversity, equity, and inclusion. And then the second group that they wanted to interview were their classmates, their peers, to talk about, to get a sense of how their peers view some of the same things that these professionals view. So let me introduce you to our speakers, just so you know who you're going to be hearing from, aside from the 3 students in the room. Professor Darren Regine is a faculty member in physician assistant studies at the University of Utah, and he is the PA program director of inclusion and diversity. And if you're a physician assistant student, you may have read some of his writings or read about him. He's been written up in some of the physician assistant journals. Dr. Dee Matthews is the Vice Chair for Equity, Diversity, and Inclusion for the Division of Biokinesiology and Physical Therapy at the University of Southern California. And finally, Dr. Shanice Higgins is the chair of the occupational therapy program at Kettering College. She's a member of the American Occupational Therapy Association Diversity, Equity, and Inclusion Task Force, and she's actually the Diversity, Equity, and Inclusion Officer for Kettering College. And Kettering is a majority healthcare professions higher education institution. So 3 people who really have some expertise. Let them introduce themselves to you.
I'm an associate professor at the University of Utah PA program, Department of Family and Preventive Medicine. Also, I'm the director of inclusion and diversity for the PA program. I'm the chair of the Diversity and Inclusion Advancement Committee for the department. I've been a core faculty member in the program for about 10 years and adjunct before that. So I've been working with the PA program for about 16 years now.
My name is Dee Dee Matthews. I am a doctor of physical therapy. And I'm on faculty at the University of Southern California in Los Angeles, where I teach regarding clinical neuro management. And I also serve as our vice chair of equity, diversity, and inclusion.
So I am Dr. Shanice Higgins. I started out, I'm an occupational therapist. I started out in practice working in the school systems. I worked in pre-K to middle school in a rural community. I also transitioned, at that time I was doing part-time PRN at an inpatient psych unit in the same area. I love psych. I fell in love with it while I was on my level 2 rotations. And so a job opened up on an inpatient psych unit closer to where I lived at. And so I transitioned out of education and then into inpatient psych. I stayed there until they closed down my unit. The hospital actually shuttered the unit because of lack of reimbursement dollars at the time, and it had to do with the levies not getting passed, because I don't know how much you guys know and pay attention to the not hot topics related to politics, but sometimes the more important ones, but they get less attention, and that's public health dollars. And those dollars are typically supported by tax dollars that you receive. And so long story short, ours didn't pass. We weren't getting paid. We weren't getting reimbursed. And so they shut our unit down. At the same time, they closed down several of the state hospitals in the area. And I think all of this kind of relates to your topic, because this is a disadvantaged population. Oftentimes, people who have psychosocial issues often struggle in other areas of life. And so because there are bias against this population, they're not always given the same level of care that others of us are. And so I did that until they closed, and then I transitioned into higher education, academia. And I've been teaching here for the past 5 years. I am currently the program director at Kettering College for the OTD program, entry level. I started out as one of the founding faculty members. I was the admissions coordinator for several years. I was the capstone coordinator for a couple years. Now the program director, and I am also the diversity, equity, and inclusion officer for the college.
So really a wonderful array of experts that we're bringing to you to talk from the health professions, the same professions we have at Springfield College. In addition, there we go. In addition, these are the students who participated in the interviews. I'm guessing some of you might be in the room, but what the 3 participants with me wanted to do was to get students from across the majors at the college and students from across years, and just sort of take some type of a cross section of, again, it's a little biased, it's people they knew, but people they knew who were willing to share and willing to be recorded and willing to take that risk. And so we are really grateful to these students for participating in the interviews. I actually have a little video of all of them saying hi. It probably runs longer than I think we want. So because I feel I've really talked enough. And as I said, I was only the person leading them down this path. I really want you to hear from our 3 students. And so I am going to, if this works, turn it over to them. Xavier?
Perfect. Hello. So I'll be talking about diverse healthcare. So when we speak about healthcare, it's hard not to address social determinants. So I put a little diagram here. So we have economic stability, social and community context, neighborhood environment, healthcare, education, right? And we can see how all these categories are all intertwined and they can affect one another. 3 contributors to health disparities that I noted were cultural differences, lack of access to healthcare, and then high rates of poverty and unemployment all lead to these health disparities that we see. So I'm going to unpack each one a little bit more. So for cultural differences, at first it was kind of hard to break it down. It seemed like such a big concept to unpack. So on baseline, we know cultures vary in customs, beliefs, views, and ways of life. With that information, do we look at culture in terms of that of the public, or do we have responsibility to look at the cultural makeup of our providers as well? How do they align? How do they differ? We know that 70% of healthcare providers in our nation are Caucasian, yet our country is referred to as a boiling pot of individuals of vast ethnic and cultural backgrounds. So I think it's safe to say that healthcare providers, the makeup isn't reflective of those they're treating. So what to do? So I looked at the Institute of Medicine, and one of the resources actually Dr. Chevan provided to us. And what they looked at was how the health professions and the makeup affects health disparities. So one of their key strategies in combating health disparities was looking at an increase in minority groups, right, and how that can decrease health disparity. So how to address it? Cultural competence. I know a lot of the health care students, I've heard of that word. So pretty much it means learning about various cultures, but it's still a baseline thing because we want to be patient and client-centered as practitioners. So you want to take the time to get to know and understand the person sitting in front of you, because even when you're trying to apply what you know or generalize what you've learned about a certain subgroup, you might fall short because people vary, even those of the same ethnic or cultural background. So second off, that lack of access in healthcare, I'm going to link it with high rates of poverty and unemployment because I think they go hand in hand. So once again, we know social determinants of health exist. They can lead to limited access to healthcare and then also quality of healthcare. One thing that's important to also speak about is insurance, right, and discrimination of insurance. So we know some healthcare providers are able to pick and choose which insurances they accept, which will leave those with lower level insurances kind of in the dust, right? So now we have a predominantly minority group population within lower socioeconomic areas, whether that impacts their ability to transport, right, to appointments. Those who are more vulnerable to comorbidities, whether it be diabetes, high blood pressure, hypertension, obesity, poor diet, just more and more barriers to these individuals and subgroups, making it hard to access the healthcare system. I think a good example to bring up is COVID, right? 19, it's very prevalent and evident. If you just look at the statistics and the numbers of those affected with COVID, especially early on, I actually had to talk to one of my professors. We looked at certain boroughs of New York, right, getting hit really hard and really bad real early on, right? And especially those people with respiratory and breathing conditions. We know that COVID actually is expressed more severely in those populations. So with that in mind, looking at mortality rates of Black and Hispanic communities, for instance, it was astonishing. You can see the disproportionate impact of COVID when you analyze subgroups kind of on this scale, right? And this all will lead back to these social determinants of health. And then, yeah. And then lastly, just one last point I want to make before we get into the interviews is, so back to this Institute of Medicine, we said if minority health professions or minority health individuals in the professional field are more likely to serve minority and medically underserved populations coming out of research. And then patients will also feel a higher level of comfort and trust when they can identify with their provider, right? Well, that will lead to adherence, so making the patients more likely to both adhere and comply to a plan of care, which will hopefully lower these health disparities that we see.
I think that if we look to science and research on the area, we can see clearly that health disparities exist within our country and as well as within the world. And I think that a big piece of why is going back to our understanding of how we treat people and recognizing the partnership that is necessary between the provider and the person, right? So I may come to treating a group of individuals who look, either look similar or from a certain area, whatever, have a certain amount of money, class, that type of thing, and assume that these are the reasons why these individuals have these problems. So I'm coming and laying upon them my assumptions about what their problems are. And I think it's really important for us, if we're talking about health disparities, to engage with that population to understand really what are the true challenges of those people. Because without coming humbly to those people with that in mind, with that, from that perspective of investigating why do these challenges exist, and really, really, truly looking for what those challenges and barriers and problems are. Without doing so, we're going to provide solutions to people that do not work for them, which allows health disparities to grow and grow. And so I think a big part of being a good healthcare practitioner, whether it's a physical therapist or anybody else, is really looking to, coming with your own experience and expertise on the problem and potential solutions to that problem, but also being open to work with that individual or that group of individuals to try to understand from their perspective what the challenges are, because in order to make a really long and lasting solution, it has to take both of those. So.
Do you think that your healthcare provider has your best interest at heart?
Yeah, I do.
I believe they do. I've known them pretty much my whole life because they were friends with my pediatrician, so I've had them coordinating my entire life. I think they understand me. It's just pretty basic procedure when I go.
Not really. I feel like my doctor is not a person of color, but the people like outside, like in the office, are people of color, so I feel like they can understand a little bit more. But when it comes to my doctor, I feel like I have to constantly explain what it is that I'm experiencing or what I'm looking for.
Yeah, I think he definitely has my interests at heart. He tries to get to know me and make conversation with me on top of why I'm there. And with others, I have heard the same response for me personally.
Personally, I believe that my healthcare provider has my best interests at heart, and I could probably attribute that to her also being a woman of color. So it's different when you see someone who looks like you in the healthcare field, because you have something to relate to and you can trust them more. And I feel like there's a lack of diversity in the healthcare field, and that's definitely something we need to work on. And I feel that it would help with the inequality in the healthcare field.
I only really see my healthcare provider once a year. I feel like when I'm there and able to talk to him, he is understanding, but it's not someone I talk to regularly. So I would say in the moment, like going for a physical, like he was able to answer everything that I've asked.
I do. I've been very fortunate to grow up close with my healthcare provider as a family friend, and I've been with her for the past 21 years. She's also Hispanic like myself, so she's always been very closely attentive to my needs and what I've like always needed from her, and just being able to communicate with my mom, with me, she's always been there.
Personally, I tend to like that my primary care is a female, just so I feel like we have a better understanding and I can trust that person more.
I think that for me, I'm on still my parents' healthcare, and like it's good, and I feel like they understand me, but I'm also a white middle-class citizen, and so I feel like it would be a lot different situation if I was in a minority, and I understand that I have that privilege, and I just wish that everyone could have that opportunity that I have, because it's just not really fair for me to have it and other people to not have it simply because of the color of their skin or the amount of money they have.
So now getting a little more personal, do you feel that your primary care provider treats you as kind of that whole person and understands you? And then if you could talk more about the importance of that.
No, they see me, they treat me generally nice, you know, but they don't look at any type of identity, anything like that. They don't even ask those questions, right? They probably don't even know my ethnicity or anything like that. So, which pretty common, right? And they're good providers. I have no qualms with that, but they haven't asked me anything in terms of how am I feeling during COVID? How am I feeling during all the murders and racial injustice, and what's my stress level related to my ethnicity and my racial identity, and so that, and it's huge, but it's more like, let's just talk about your general wellness, right, or health. So those are things that are important, you know, and if they don't address that, then maybe, you know, I think I know where you're going with this, is that it makes a difference, because I don't know, I feel okay, but I don't know how much I trust this person entirely, you know, because they haven't even addressed the things. And do they give me an opportunity to talk about it? You know, they're in a hurry. You know, they have 15 minutes to address me, and then they have to see the next patient. So, to answer your question, I think it could be better. I've had worse primary care providers who, you would think that a family medicine provider would understand these things, but it's not really true. And you know, maybe if I had a primary care provider of color, that'd make a difference too, because then they would understand where I'm coming from. Maybe that makes a difference, because a lot of well-intentioned white folks don't know how to ask these questions. It's almost like it's intimidating, right? It's just, you know, I mean, you guys have heard this. I want to help. How do I do this? Right? And it can happen. And as a clinician, you're going to be asking that same question. It's like, oh my God, I don't know how to address this, right? Even asking people in a correct way, where are you from, without making a stereotype or invalidation, right? I mean, those are the things that I'm quite aware of, because I teach some of these classes around that area. But and I'm not going to say anything to my provider about that, right? But I could, maybe I should, but it's hard, right? As the patient, you're kind of like, oh, whatever. You either follow their practice and stay with them, or you leave. And so I'm not going to fire my current provider. Actually, I like her, and she's a good doctor. And plus, I know her. She's a faculty member with me too. So, but she never asks me these things. Maybe because she doesn't think she has to, because she knows me. I don't know.
Okay, so I'm going to be tackling the importance of the patient-provider relationship. So as expressed by some of the students and professionals that we've interviewed, not all people feel understood by their provider. The reasons for this can differ patient to patient. For some, the identity matters. Many feel better able to relate to a practitioner who is similar to them, yet a provider who suits their needs is not always an option. For the patient who has limited or no choice to who their provider is, getting the help they need can be delayed due to lack of comfort or not feeling understood by their provider. For future and current healthcare professionals, it is imperative to build trust between yourself and the patient. Time with patients is often limited, but a patient is not simply defined by their condition or health status. You have to collaborate with the patient or client to see how they feel, what they believe, and what their goals are. From there, you work together to build attainable and realistic goals that are centered around the patient and their beliefs. Building trust does not happen overnight. You have to be open-minded and you have to treat with every patient that you treat. So patient-centered care should not be optional. To provide the most optimal care, it starts with the patient. You must be willing to learn how to effectively communicate with that patient, respect their culture, and empathize with them. It's all about collaboration. In the 15 minutes or 30 minutes or hour that you have with the patient, ask them how they're doing emotionally, especially given the current circumstances of living during a pandemic or with the ongoing social injustices that are very prevalent today. Get to know them beyond their disorder or injury or condition. Become their advocate, especially to the ones who are underserved.
What is the first thing that comes to mind when you think of healthcare?
Expensive.
It's had better times, honestly, but I just think there should be more access to insurance for more people because the prices are ridiculous. And also I've heard from like getting healthcare bills back, like when you go into the hospital, like asking them to like rework it and getting like thousands taken off is kind of like insane to me. And I don't know why they wouldn't just do that for you in the first place.
Interesting.
That follows in line.
Complete coverage of wellness, whatever it may be, mental, physical, mostly physical, but I'd say mental is definitely important.
Healthcare, I personally think about nurses just because this could be like a biased thing, but one of my best friends, she's a nursing major, and I know they're working so hard right now, especially in this time, and there's not enough healthcare to go around for everybody that needs it, especially in like maybe lower income areas. And I just don't think that's right. But yeah, healthcare. That's.
The first thing that comes to mind is I think about like especially what's going on right now with politics and how possibly like universal healthcare or free healthcare can be taken away. That's really concerning to me because I think that healthcare is something that everyone deserves and everyone should have equal access to, and also have the same like level of treatment. And I think that a lot of cases that isn't what happens, especially with people that are living in lower income areas when they don't have that access to healthcare. So I think that like when I think about healthcare, I think about wanting to improve access for everyone and wanting to improve the quality of healthcare for everyone.
When I think of healthcare, I think of just improving one's state of being and quality of life.
Perfect.
Expensive.
When I think of healthcare, I think about going to the doctor. I think about frontline workers, doctors, and I think about getting my physical exam.
Okay.
Yearly.
Definitely, the first thing that comes to mind is insurance.
Yeah.
To be honest with you, and like the way that medical bills are super high right now. Some people can't be living off of, can't afford to go in to emergency care. But yeah.
So I mean, for healthcare, I mean, my major, I consider that a healthcare profession, and it's more or less just making sure, as a clinician, you're giving the best form of healthcare to whoever's your client.
What is the first thing that comes to mind when you think of healthcare?
when I think of healthcare in general is, I think generosity, just because we have to be caring and generous to people outside of ourselves in order to do a good job of what we're doing. Sometimes that requires us to go above and beyond, you know, what is technically required of us in order to give the best care to a person. So that's how I think of healthcare.
Healthcare system. So my lens will captures the health disparities. So that's what I think of when I think of that is health disparities, social determinants of health, you know, why certain communities are fare worse than others. You know, those are the things that come to mind, generally speaking, if I were to take that general statement and say what comes to mind. You know, maybe it's cynical, but that's my job, is to look at these things. So that's
probably the lack of healthcare services for people who have mental health conditions.
All right, I'm going to tackle equity versus equality and how to create a more equitable system. So to start off, I want to show from the student perspective. So if we could show that student video first.
Do you know the difference between equity and equality?
Yeah.
What's the difference?
Equality is basically trying to make everything equal for everybody, and equity is like doing the most to make it equal for everyone, but it to benefit others that are, I don't know how to explain this.
That's okay.
I mean, I know equality is just focusing on everyone having equal opportunities in life throughout anything. And then equity, I couldn't really tell you, to be quite honest.
That's okay.
Yes, I do. So equality is when you give everyone the same resources, but equity is when you give people what they need. And I think that's like something that's really important, because equality doesn't necessarily make things equal, because not everyone has the same opportunities and same chance to do something, because they just don't have all the resources they need.
Awesome. So if we could go back to that slideshow. Based on that, it's pretty easy to see. I mean, I know we only had 3 perspectives there, but not everybody knows the difference between equity and equality. It might seem like equality is what we're after, but at the end of the day, we need an equitable healthcare system to ensure treatment for everybody and treat everyone with what they need, versus equality, which treats everyone the same way. So I have this picture here of people reaching up to grab an apple on a tree, and equality would be giving them all the same sized box to stand on, regardless of their height. Equity would be giving them the box they need to stand on to all reach the tree and get to their same end goal. So I'd like to share with you some of the ways that we can go about creating a more equitable system by going over this amazing resource that Dr. Chevan shared with us called the Black Rehabilitation Manifesto. This came out this month, so it's a very current resource. Over 90 PTs, OTs, and speech language pathologists and students worked to create a basis for more equitable treatment across these professions. So I want to start by talking about this. I'm just going to read a blurb from the summary. So the Black Rehabilitation Manifesto requires the acknowledgement of the harmful nature of the status quo in rehabilitative advocacy, education, practice, and community engagement. The status quo has resulted in increased healthcare costs, widening of the gap in individualized care, and increased disability and premature deaths in Black communities. The manifesto represents a collaborative effort of Black practitioners, students, and consumers to verbalize our expectations of stakeholders involved in rehabilitation advocacy, community engagement, practice, research, and education. So they not only in this manifesto listed what is wrong with the current system that we have, but also gave a list of ways to improve this. So I'm just going to read 3 top points that I think really stood out to me. So ensuring inclusive climates within all practice settings and educational programs through routine climate scans, action plans, and other surveillance measures and implementations to address threats to inclusivity. So this is like actually getting outcome measures of what it means to have an inclusive climate in your practice. Every office should have these like maybe surveys people could take, and developing those outcome measures will help us accurately judge an inclusive environment for everyone. Another one was mandating cultural awareness, humility, and responsiveness education and training as requirements for initial licensure and renewal in all of these professions, which this is really where we come in. We are able to advocate for legislator when we are in these professions, and that's what we need to be doing. We can mandate cultural awareness, humility, and responsiveness education and training. We can do that. We just need to fight for it, and that would be a great way to ensure that our patients are being understood the way they need to be. And lastly, one that I really loved was documenting micro and macro aggressions and requiring professional development plans and action to protect rehabilitation practitioners and the public. So not only having a plan to, or like recognizing these micro and macro aggressions, but also having a plan to deal with them to protect the practitioners and the patients. I encourage you all to take a look at this manifesto. It's a lot longer than the little blurb I was able to give you here, but these are all creative ways that we can create a more equitable system. You just need to push your employers to follow these guidelines, stay educated, stay up to date, and be creative. And we'll hear more about this from the professionals.
What's the difference between equality and equity?
So when we talk, the buzzword is equity, right? So I like to make it simple. It's like giving whatever someone needs to get to the same place, right? So leveling the playing field, okay? Versus equality, you can use all those different analogies like the 100-yard dash, right? Everybody has an equal chance to win or finish. Some people are 30 yards ahead, right? Or the baseball analogy. Some people are already on third base, but everybody has a chance to score. You've probably seen that one cartoon where there's the three kids trying to look over the fence to watch the baseball game. And and they all have equal boxes to stand on, but one person's really tall, one person's on the kind of medium, and then there's a really short person. And what they show is that you give the person who needs the most the biggest box so they can see. And then the next step is removing the fence, right? So like if we look at education, because we do a holistic review and we do equity, it's not just equality. Of course, we have to follow the law in terms of equality, but we also look at giving people, like I was telling you, points on their application if they come from first-generation college student, federally meeting federal guidelines for poverty, going to like Title I schools or free lunch schools or any of that stuff. Those are things where we say, okay, here's that. The equity would be giving those individuals points because they traveled further, right? If it was just equality and say, well, yeah, we're fair, everybody has a chance. And then when they get in the class, we don't even have an exam failure policy. We don't say 3 strikes, you're out. We look at everything we can and say, how can we get this individual where they need to be? Oh, they need a tutor. Let's give them a tutor. We need to get them to counseling. We need to, whatever it may be, right? Not just, everybody has a chance to take this test and learn about this disease. That's equality, right?
Do you feel that everyone is treated equally in the healthcare system?
I don't think that everybody is treated equally. Well, for a few reasons, though, I don't think that equal treatment is really what we should be striving for anyways. I think it should be equitable treatment, because the care that's needed by different people, because of for many different reasons, race, socioeconomic status, age, gender, for many different reasons, the treatment might need to be slightly different, or brought from or a certain perspective is brought into light in order to be able to treat people with the best of our abilities. With respect to healthcare currently as it is, I don't think there's equal healthcare. And a big part of that is, I mean, there's many ways that you can look at that, but one way that I would describe that is just simply access. If healthcare is not equally accessible to all people, regardless of, again, socioeconomic status, geographic location, race, gender, and the other myriad of things that we could consider, then, you know, if people can't get the health care, then there's an equality issue right then and there. And then add to that just the way that we, as humans, implicit bias comes into play in how we treat other people. And without us taking a very concerted effort in order to mitigate those implicit biases, all of us, our treatment is going to be affected by that. My treatment, your treatment, everybody's treatment is going to be affected by it. So we need to be educated and understanding of how we can mitigate, how we can help to mitigate those biases so that we can provide equal treatment to all people.
All right. So again, the students have learned a lot. We've looked at a lot of different issues, and we've really explored what it's going to mean for them to enter into the health professions that really look no different from the year when I entered into the health professions. And for me, that's a long, long time ago. This video that I'm going to sort of skip over now, I have to admit, because we're getting lengthy on the videos, is 8 minutes of instruction on how to do admissions right and how to recruit faculty the right way. And I'm saving this one to share with my colleagues when we have a school meeting, because again, the experts from Utah and from Kettering and from USC really tell us what to do. But I am going to tell you a little bit about what just flew across my Twitter feed in the biggest way this summer. And it was an article by a man named Don Berwick called The Moral Determinants of Health. And Don Berwick has talked about this over and over and over again. And I've seen this quote every single place I've gone this fall, every conference I've virtually gone to. Healers are called to heal when the fabric of communities upon which health depends is torn. Then healers are called to mend it. And that's the essence of what we're talking about when we're talking about improving the health professions. Dr. Berwick came up with 7 different things that we need to change. And I'm going to talk about them in a minute, but I want you to start to imagine what they might be. 7 different interventions we need to apply as health professionals. And if you're thinking those interventions are more vaccines and more access, kind of yes and kind of no. First, I'm going to let our guests say goodbye to you.
I wish you all luck on your work and becoming great, in tune healthcare professionals who will be paying attention to the health and culture and how those two things intertwine.
Yeah, and then you look at equality and equity, right? And say this isn't an equitable practice. Otherwise, we'd have more potential for a diverser classroom. Or why aren't women and LGBT folks getting in or in leadership positions? You know, you can look at this in so many aspects. Whatever it is that you're passionate about, you should be able to do it.
So I think the patient-centered approach is huge, and I think we all need to take it to heart very, very seriously if we want to be effective with our patients.
So here are the 7. Dr. Berwick urges us to imagine for a moment that the moral law within commanded shared endeavor for securing the health of communities, as opposed to what you're all learning in school right now, which is, how do I treat disease? How do I treat disability? How do I help people and rehabilitate them? Imagine further that the healing professions together saw themselves as bearers of that news and leaders of that change. What would the physicians, nurses, and institutions of U.S. healthcare insist on and help lead as an agenda for action? And this is what he proposes as the 7-point agenda for action for healthcare providers and for our healthcare institutions and for academic institutions to think about who it is that we're bringing into our programs. First of all, the United States is not a signatory to the human rights statement, and so human rights as an action. Healthcare as a human right. You heard some people come up with statements like, well, healthcare is a right in the United States. Actually, it's not. And it needs to be a right in the United States. We need to work to reverse climate change because the impact of climate change is tremendous on everyone's health, and even more so on the health of all kinds of populations. We must reform the US criminal justice system. It's a health issue. We need compassionate immigration reform. It's a health issue. We have to work to end hunger and homelessness. That's a health issue. And we have to make sure that we're really acting in a democracy where every single person's vote counts. That's a health issue. So really, we should be revising the curriculum of everything you're studying here. And instead of having you take clinical medicine courses, and instead of having you take courses on, sorry, my colleagues, musculoskeletal care and neuromuscular care and cardiopulmonary and vascular care, the courses you should be taking are how we can conduct a morally guided campaign to improve health in the United States. And I applaud Dr. Berwick for putting this out in JAMA and for calling to us to say, by saying we need to call out not just the social determinants of health, but also the moral determinants of health, because without that, we're not going to find the will to act. And remember, we said we wanted to leave you with the will to act. And so this is what we're thinking about when we talk about action. When we talked about the action verbs as a group of 4, we talked about speaking out and writing editorials and writing to newspapers and writing to medical journals, just as Dr. Berwick did. Because remember, his Moral Determinants of Health was published in JAMA, the Journal of the American Medical Association. Organizing and lobbying, advocating and helping, engaging and voting and caring. And if these are not the verbs you're hearing when you're studying in your health professions, we need to modify the curriculum. And if you need some reading, turns out I'm the source of reading. Ask the 3 students who worked with me. The list is even longer than this, but this is a great starting point, these particular documents. And if any of you happen to be physical therapy students and you're wondering, wait, where's my faculty? That S. Brooks right there, that's Dr. Brooks. She has been co-author on an article about purposeful recruitment strategies to increase diversity in physical therapist education, something that all physical therapy programs need to pay more attention to. And we want to thank everyone who was part of this presentation. Many, 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 many students. Not everybody got in. We have so much video footage. It's unbelievable. These students spent hours talking to people, and they actually have 3 new friends, a faculty member at the University of Utah, a faculty member at USC, and a faculty member at Kettering. And a special shout out and great thanks for this amazing week to Felicia, and a super special shout out to Charisse for all the work that they've done to bring seat at the table. I am astounded by what this week has done for everyone. So we invite you. Go ahead, ask hard questions, comments encouraged. We open the floor. And I would ask my 3 presenters also to open their mics. And thank you for being with us. If you guys want to say anything, go ahead.
I just want to thank everyone who attended. It means a lot.
Thank you.
I have a question for the students that did the interviewing with our community. Did you find that there was any pushback, or was there anything shocking as you were conducting these interviews and doing this research?
I don't believe that I found anything shocking, which makes sense because if you're going to Springfield College, you might be from a certain class, so we might have been getting a pretty biased sample because of that. So there wasn't a great difference between every interview.
Right, I'd have to agree. A lot of the students, like Katie said, who we interviewed kind of have that same socioeconomic status where health might not have been a huge topic of like a disadvantage.
Yeah, I also agree. I also saw the same trends. So, yeah.
Else want to share an opinion, share a comment, or ask a question? We're here.
There's a question in the chat. I can read it. Let's see. When did your if I can read, when you did your interviews, was it hard to not want to educate others? Example, equity versus equality, and not just listen.
Yeah, that was very hard. In the interview process, I think the three of us are very social, so it's more natural for us to have a free-flowing conversation, just listening to both the students and the professionals talk and not being able to respond like, yes, I agree with you, or, oh, actually, let's change it in this direction. Like, it's very difficult, but I know with some students, we interviewed separately, but when I interviewed some students, having conversations afterwards was really great, so that was nice.
Yeah, and to even add on to that, we didn't want to lead students with our questioning, so we tried to keep it in like a good format, so we weren't leading and getting certain answers we wanted.
Everyone, I actually do have a question that's a little bit targeted at Dr. Chevan, but also I'd love to hear the other DPT students and their thoughts on this. But when we talk about the ways that we can kind of change our programs and incorporate into our curriculum kind of these diversity initiatives, and that's such a buzzword, right? Is like diversity initiatives, but in a curriculum that is so packed and so tight, I mean, it seems, I mean, Dr. Chevan's laughing because I'm a DPT student as well, but when we have these curriculums that are so packed, I think it's easy for students who don't share mindsets of the importance of diversity and equality to kind of fly under the radar. So what should programs and how do we as a cohort and as like a program approach the idea of kind of confronting these ideas that kind of lay low in healthcare providers until they're already in the system?
I'm laughing because the question you're asking is, I feel like I'm in, once a year I go to this meeting with lots and lots of other program directors, over 200 DPT program directors. And this comes to the floor, and invariably there are a bunch of program directors who stand up and say, there's too much in the curriculum. How could we add this? And you know what? There are things you have to add. There are things where sometimes it's not a choice. I know how you'd feel if I said, hey, we're taking the measurement of heart rate and blood pressure out of the curriculum. That's not a choice. You can't take that out of the curriculum. Here's another thing that's not a choice. Ensuring that the way that we teach incorporates all the things that we were talking about today. We don't actually necessarily have to create separate courses. And it's maybe even some academics argue that the separate course approach is part of the problem, that actually all of this should always be integrated into every course, that there should be diversity, equity, inclusion objectives in every course in the curriculum. So I could turn this around to you, Allison, because I know that you're taking anatomy, and say, what objective do you think ought to be written into an anatomy course? What objective ought to be written into your course on education? What objective ought to be written into the course that you're going to take on clinical medicine? I think clinical medicine, you're probably sitting there saying, well, that's easy. Right? Because clinical medicine, we're talking about all kinds of issues around health and healthcare and who gets sick and how we provide interventions. And maybe we ought to really think about, well, what are the root causes when we do clinical medicine? Because we talk about epidemiology, but we're not always talking about root causes. Like when I say epidemiology of asthma, you're thinking, oh, I get it. I can get down to the cell level and tell you what's causing asthma. But I'm going to go back to that thing about climate change and tell you that the root cause of asthma in Springfield is the way that the highway was built through certain neighborhoods that have lower socioeconomic status and have different demographics, and now there's more asthma. We should be talking about root cause, because if we talk that way, you're going to come in and say, when I see a patient with asthma, I can think about the cells, I can think about heart rate, I can think about the pulmonary system, I can think about how to provide care, and when I'm done, I should be marching down to City Hall to talk about what we can do to change the city so that I see less asthma. And we should teach both things at the same time. So yeah, curriculum's full. You're right, absolutely. Same in physician assistant studies, same in occupational therapy. Oh, same in every program at the college. The curriculum is full. The problem is that what we're not doing is saying, how do we take the curriculum apart and rebuild it so that it's full of the things it needs to be full of? I'll let the students answer too.
We have 2 more questions I see coming in. After exploring this topic, what was the biggest takeaway and action item for you personally?
That's certainly for the students.
Can I go back to Allie's question quick, just to answer that at another perspective? I know the core curriculum is changing, the undergraduate core curriculum is changing, but I think there is a certain role that advisors can play in this as well. There are certain courses, and we're going to be releasing some fact sheets after this presentation, so be on the lookout for those, of certain courses you can take in undergraduate work, which too late for us, but I digress. And in these courses in undergraduate work, you'll really get an eye-opening experience. Like I mentioned, sociology of health and healthcare with Susan Joel. So advisors can maybe like show their advisees where to go in those directions for their undergraduate work, just to get a heads up on it before the graduate program.
I'll start with the next question. After exploring this topic, what was the biggest take and action item for you personally? I'd say for me, it has to be advocacy. Definitely the push to be an advocate and to advocate for people, and also time. I mean, on the actually conducting the interviews and stuff and balancing it with school. So it got a little stressful at times, but it really showed me that everyone's so quick to say there's not enough time in a day, but if it really is important to you, then you always figure it out and find time. So that's my biggest takeaway.
Yeah, I also felt similarly. So, but in addition to that, I feel like my biggest thing was that at every level, we have to do better. It's not just at the practitioner level. It's not just at a certain state level. Like, there needs to be a lot more done. And as a collective, we should be working towards those goals and trying to advocate in that direction.
I totally agree with both of you. On top of that, I've always been very interested in politics and legislator, and I really thought that this was a call to action to really get involved with that in the future. And specifically the interview with Dr. Rougine was very eye-opening in the fact that we have way more power than we think we do, even as students now. It doesn't need to start once we're practicing. We can join certain organizations that we can have a say in that legislator now. So I think that was a really big call to action for me to get involved in that way in the future.
Lisa Holmes has another question. She says, how do we attract BIPOC students? And for anyone that doesn't know, BIPOC, Black, Indigenous, people of color, high school students to the health professions in Springfield College in particular.
So in what Springfield College can do, I'm not too sure if it's being done or whatnot, but I know one of the professors or one of the experts had mentioned how they have an implemented program within the surrounding high schools about, talking to students, especially those of diverse populations, about getting into the healthcare field and trying to find these initiatives to, make it a possibility. So, and I think that also kind of encompasses equity. So we talked about, the GRE, for example, and how that test is meant to benefit a certain group of people, whether you can afford it, whether you can afford the supports for it, right? Can you take a class? Can you do all these things? And if you are, say, a first generation student or a first generation individual applying to college, do you have the funds to apply, right? There's an application fee for various colleges. And if you need to get into a program and say your grades aren't the best, then you have to apply to more programs, a higher financial disadvantage. So, I mean, just trying to find different ways to make it possible, right, and equitable for everyone is a push that Springfield and various institutions of the health sciences needs to look into.
The other thing that, Lisa, that some of our guests talked about, I didn't include the video, is something that is used heavily in nursing and in medicine, which is called holistic admissions. It's a really different approach to admissions from the approach that's typically taken. And we've looked, you know, as a department, we have a role in admissions, but our role is on some level it's limited. We're not doing the recruitment. We're not out there enough trying to get in the students. I know we've talked in our department about potentially taking on some of that role and using some opportunities to do that, and then also moving our admissions into something that's a little more holistic. I think Dr. Regine really alluded to that, this idea that what you're going to do is develop a system where you're working to create equity in admissions, and that's what holistic admissions does. It really looks at, you know, did everybody start at the same spot, and if they didn't, how do we make sure that we're getting people to the same spot before we're looking at the equal data across people. I tried to get the students an interview with a woman in the American Association of Nurses to talk a little bit about the holistic initiative, because she's really the expert on that, but she's a little bit busy with some of the COVID issues in nursing. So, tough year to get interviews. I'm not sure, were there other questions?
I'd like to add on to that last question, actually, that it's not only about bringing them here, but keeping them here. And one great thing that we talked about in a couple of the professional interviews is that if you show up to this program and you're the only BIPOC person, you might not feel included, you might not feel welcomed, and you need to create an environment where they're able to stay, because it's so easy to be like, I'm not cut out for this because I'm not represented here. And then they leave. So it's definitely just as important about getting them in as keeping them there.
Can I add to that too? While this is not my field, students come talk to me a lot. And one of the things I think that's communicated is not only that, but there's not an encouragement of students to stay in those fields, particularly for people of color or BIPOC individuals. There's this myth that, you know, that's too hard of a major for you, right? And so they're discouraged from actually studying this area or field.
Yeah, and Felicia, the other thing is so the other piece that some people have looked at is that when you find, you know, when you're working with a student, you think, wow, this student is excellent and really could excel in the health professions. The first thing that's said to that student is, you know, you ought to be a doctor. So it turns out at Springfield College, we don't have a medical school. We're probably not going to have a medical school. We have physician assistant studies, we have OT, we have PT, we have AT, we have all these other professions. And there's actually a hierarchy in healthcare. And so when someone is identified as potentially an exceptional student, or a student who's really gonna obviously got these capabilities, physical therapy, OT, PT, PA, speech and language, it's bypassed. And part of the reason it's bypassed is because it's pretty hard to connect a student up with a mentor in the field and say, here's someone who I think you ought to talk to. This is somebody who you'll relate to. I mean, I think I will, if it's okay, Xavier, I can say that at one point there was this time where, you know, finding someone potentially who could mentor you, we have called on the same people over and over again in our program. Why do we call on the same people over and over again in our program? I won't pull up the slide, but I shared it with the students. I can show you what diversity looks like in the physical therapy program at Springfield College. We call on the same person over and over again because we just don't have that many people to call on. So there are so many issues on being able to improve admissions, and we're going to do that.
There's a comment.
Yeah, I see that.
Yeah, so Angela echoes you. Student debt is a major issue.
Yeah.
It is not always which professor, but which professors can repay your debts.
That's right. She's right. And, you know, we don't do enough at Springfield College on selling our program in all the right ways. We are a 3+3 program. That means that you get your bachelor's and your doctoral degree in 6 years. PA, same thing, bachelor's and doctoral degree. OT, bachelor's and doctoral degree. You come in, you don't have to do juries, you don't have to do secondary, there are all these things you don't have to do. And, you know, if you think about 6 years, what's usually a 4+3, which is 7 years, you spend 1 less year of tuition dollars. You earn money 1 year sooner. Oh my goodness. It's economically a concept that really should and could work to improve the diversity of our student population. And yes, I've written about that, and I always hope that that's that we're working toward. So the concept is great. Okay, anything else? And we need to begin sooner than we do, says Regina Kaufman. I think the manifesto suggests that age 4 is right, and I couldn't agree with Dr. Kaufman more, and she knows that we're working on something that's just like that, because students especially in the public schools are tracked at such a young age. The decisions are made at such a young age. And for those of you who are in college, the decision to get into college was made for you practically on the day you were born. And for people who don't come to college, probably too. And we need to change that. And everyone should have that opportunity to get to college when they get into the public schools. So yeah, we need to start at age 4. We need to get into the schools at age 4 and say, this is what a physician assistant is. This is what a physical therapist is. This is what a speech and language pathologist is, right? And, you know, speech and language pathology, that's a mouthful. Probably not a profession that you, when you were 4 years old, said, when I grow up, I want to be a speech and language pathologist. But I wouldn't mind it if a lot of people said that. Lots and lots and lots of people. So it is certainly nearing the dinner hour. I think my room has darkened since we started this. Any last comments from the students who, again, you guys, bravo. And if not, thank you everyone for joining us. And thanks again.
Thank you all for taking the time out of busy schedules. Thank you for your scholarship and participating and taking a seat at the table. We really appreciate your willingness to participate in your scholarship again. Please consider filling out the application, and we have one more day full of sessions for you tomorrow. So I hope you see you at the table tomorrow too.